So we're going to get our panelists seated, and then we'll have questions, and then I'll take questions from the audience. So our first panelist is Don Boyd, and Don is the CEO of Kaleida Health, which is a major health system in Western New York. He has decades of experience in healthcare leadership, and he's been instrumental in driving innovation and improving care. Our next panel member is Dr. Michael Galang. He is the Senior Vice President and Chief Information Officer at Catholic Health, another major health system in Western New York. His expertise lies in leveraging technology and enhancing patient outcomes and improving operational efficiency. Then next is Sarah Mullin, who is, there she is, great. She's the Director of Biomedical Informatics, the shared resource at Roswell Park Comprehensive Cancer Center, and she also co-chairs their AI task force. Her research is focused on utilizing artificial intelligence and data analytics to advance cancer research. Perfect topic and treatment. Next is Dr. Tom Quatroche, who is President and CEO of Erie County Medical Center, better known as ECMC, a top medical facility in Western New York, and it is known for its comprehensive services, including the Level 1 Trauma Center, burn treatment, behavioral health, and transplantation. This panel really is the spirit of collaboration across Western New York. Every single person here on this panel is dedicated to improving the health of our patients in Western New York, or as I now would say, transforming health of Western New York. And we are dedicated to that. We have many questions, and so we're going to move to that. I will also say that Jill has been texting me and telling me that we have about 90 people plus online. So, oh, so you're going to sit there. We're going to start with you. All right. So, Tom, what worries you about AI in healthcare?
Figure out how to work the microphone first.
What keeps you up at night?
About AI. I think the health equity piece of it, I mean, obviously we've talked about where the data is coming from and, the unconscious bias that we've had in medicine that we've spent a lot of time over the last few years talking about, and the way people have been treated is obviously affected the data sets, right? So, and the treatments. So I think, recognizing that, obviously the hope is that we collect better data moving forward. In the last few years, for example, the social determinants of health have been the conversation, but that data didn't exist prior. So I think it's a worry that we do not use the data in an inappropriate way, that people still rely on clinicians and don't try to get this information from AI in the absence of clinicians, because obviously there's a lot of data that needs to be improved before we can get to some of the inequities that have happened in healthcare over the years.
Yeah, completely. David, do you want to comment about the data sets?
Going to have this.
Yep, you guys
yes.
are good.
So I completely agree. I think in order for AI to be useful, you have to have large and diverse data sets. Now, the challenge that we run into is that the data sets themselves are oftentimes in silos or not captured at all. And so this is why I was talking a bit about not only the full capabilities of AI, but how do we enable collaboration and how do we capture data that are traditionally not captured? And we have some capabilities today. It's going to require us to build new partnerships. During the pandemic, one of the things that we realized is in order to increase vaccination rates, we didn't just focus on health systems, but we focused on public health and community-based organizations. Yep. And it was this combination of all three of those working together that allowed us to be able to build trust, capture the right data, manage it securely. But I think that's going to be a new paradigm for us because we're traditionally used to just working within the confines of our own systems.
Great, thank you. Mike, you get the next question. We've recently learned that you have apparently implemented a voice recognition software for charting. And can you share with us how it's working, how it's implemented, the usefulness? I know there's lots of docs here. I've mentioned I have to do my notes in all scripts here. Tell us how it's going.
Yeah, firstly,
Yes. Okay.
Firstly, I have to say that there isn't a lot of technology is embraced with a lot of positivity. This one that we conducted a 4-month pilot on
Hold-
what,
Hold the mic a little.
oh, sorry.
Yep, perfect,
We
much better.
conducted a 4-month pilot on what Dr. Rhew referenced earlier on ambient voice technology. 2 products that we piloted, both were deeply integrated with our electronic health records, so that was a major plus. We included about 40 practitioners, both providers and APPs across the ambulatory space, predominantly primary care, but included other non-primary care providers. It's an easy system to learn about. It took
What system
probably-
do you have?
We are actually going forward with a bridge. Not DAX Copilot that was referenced earlier here, but we did pilot both of them. The decision was really the quality of the note, and our practitioners felt that the product we selected was the better choice. But what we did in terms of implementation is it took about 30 minutes to really train most of the providers. The education materials were available online or on the actual application itself. With our EHR, there is a mobile device that you can access patient information. So the tool is actually engaged from that mobile device within the EHR. And what we found was that, number one, the aim of the study was really to help lessen the cognitive burden of the providers, and 60% felt like it did do that. And 35% felt that it did reduce the burnout and the feeling of fatigue. They also felt, the majority of them felt that if this tool wasn't available, they would be very disappointed. I think from a patient perspective, patients felt 95% of the time that the provider was very much more engaged, not behind a computer, typing in what he or she needed
Right.
to do. And so what we plan to do is extend it out to the rest of our ambulatory practices as the functionality becomes available within our EHR and ambient tool. We'll extend it out to the ED, and then nursing. Nurses use the EHR much more than the providers do, but to help with nursing completion of flow sheets, and then eventually to the inpatient world. One interesting story, the power of AI, the model that or the product that we chose supports 14 languages. We had a Ukrainian provider that sees a lot of Ukrainian patients, and the tool that we selected does support Russian, but not Ukrainian. We said, give it a try. Behold, it actually summarized, organized the note perfectly. And so she continues to use that.
In Ukrainian?
Yes.
So wait, learn Ukrainian?
Well, there's some
Sorry.
overlap with Russian too. Yeah.
Wow,
somehow did.
wow. So how is this connected with your EMR? You're on Epic, is that right?
Yeah. Yes.
How does that work? How
It's very much embedded within Epic.
okay, it's
so-
under the firewall?
Pardon me?
It's under the Epic firewall,
Yes.
right? Okay.
And
very
so
cool.
there's a mobile Epic tool
Yep.
that you use called Haiku.
Yep,
And that a bridge tool is embedded within that. You can start that application by using your smartphone. That is the recorder. And
Yep.
then what we also learned is that practitioners aren't comfortable in verbalizing the physical exam. So you can actually pause the recording and then do it after the visit. So
awesome.
the HPI and the assessment and plan are probably the most added value, because those are the things where you need a lot of critical thinking and thought and how to put that together. The AI does that and helps you organize that. So
That's awesome. Well, we're going to pivot to my friend Dawn. Dawn, how do you envision healthcare workers and the future leaders? We've got medical students, residents are interviewing and putting out their applications as of 9 o'clock last Wednesday. How do you think AI is going to transform the way we take care of patients?
Well, first of all, good morning, everyone, and thank you, Dr. Brashear, for having us. It's good to see some of my former professors from the School of Medicine, or sorry, I'm not a doctor, School of Management. Sorry, little bit of a slip here.
You want to
Um,
introduce our friend here in the front row?
Yeah, so I would like to. So Dr. Iyer, who's the chair of the school, or the dean, excuse me, I'm pivoting from School of Medicine. the Dean of School of Management. So it's good to see you. Hi there, Doctor. Good to see you again. So Allison, the question was, how do we see it transforming? So I think it would be helpful just to build a little bit on what Dr. Rhew talked about the context. So Tom and I and others here, obviously are on the provider side. So just to give you a little bit of context of the reality of what many of our providers face. So you talked about how healthcare, there's some debate about just the data set. There's some that believe that 30% of all the world's data is healthcare data. That's debatable, but there are people that it is the fastest growing segment of data. And Tom talked about how it's largely unstructured. There are errors in that data. So one of the first promises of AI is the ability to synthesize all of that data in a meaningful, easy way for providers and for their nurses to be able to summarize the chart. So one of the first areas that we're looking at is just to improve the efficiency and the effectiveness of all of that data, because while it is the fastest growing data set, it's the least utilized data of all of the data that's available in the world. Only 3 to 5% of all healthcare data is actually utilized. Just think about that. So that's the first piece, Allison. I think the other thing, and you talked about it, we're actually piloting DAX Copilot right now, is the ability to simplify documentation. So it's incredibly laborious to navigate. And so there was a study, I'll give you an example. There was a study that was done, perhaps you're familiar with this, David. The School of Public Health, University of Minnesota, studied hundreds of thousands of physicians and the average amount of time that they spend with a patient, and it's 18 minutes. So if you think about an interaction that you would have with a patient in a clinical setting, Cerner, which is a large internationally installed electronic record, which is the one that we're on, studied over 100 million patient visits. And what they found was the amount of time that the provider interfaced with the electronic health record was 16 minutes. So that's less than 5 minutes interfacing with the patient. So the ability for ambient listening to have a completely different experience for the patient, and you touched on it, but I'll say it a little different. For the generation, since the beginning of time, healthcare has been institutionally focused. It's been health system or hospital focused. The promise of AI is to make it more centric. And so when you think about all of the social determinants, health and bias, and all the things that Tom and Dr. talked about, to be able in that time, that engagement of time with the patient, to identify them, have the technology be able to summarize that and then make the connections. The experience for patients is it'll be more democratic, it'll be more customized, and it'll be certainly more than. When you think about burnout, your point about nurses' time in the record, the ability to simple process. Your physicians know, you see this every day. The handoff from one nurse from shift to shift, right? How do you capture what happened across all of your patients seamlessly and relate it to the next person that's going to care for you? AI has. And structure that communication. It's simple and easy so that the important things are used. So that's how I would just say in the near term, how you can tell I'm excited about this. We're excited about this. I think how it's going to make a difference.
Yeah. I think the patient centeredness is so important because as we try to transform healthcare, it's about the patient and their families. The best place for the patient and their family is at home. So speaking about patients, we talked a little bit about cancer, and Sarah Mullin is with Roswell Park Comprehensive Cancer Center. And can you speak a little bit about how AI is being used about cancer detection, a little bit what David talked about, and what you would like to see in development from the patient's perspective? So we
Sure.
don't have these myths that we hear about.
Yeah, so actually, currently we are not using any sort of AI tool for cancer detection or diagnosis. And that's primarily due to some of the standards that Dr. Rhew mentioned. So currently for our AI policy, we're following the NIST standards. So 2 of those standards are that they have to be safe. And so that means that no human should be harmed, right? And the second one is it has to mitigate bias. And so a very, very, very famous example is the fact that a machine learning model was trained to identify and diagnose patients with melanoma. And it was all trained on light-skinned patients. So what happens when you give this a dark-skinned patient? really bad things. It misdiagnoses or it completely misses this patient. And so there's a lot of things to consider there. So in clinic, it's a little bit different than within research. And so a lot of like barriers and a lot of like hurdles need to happen in order to be used in clinic. However, indirectly, we are using a lot of AI tools in order to kind of improve the workflow and efficiency of the process. We have piloted DAX. In addition, we also use Eon to do natural language processing of radiology reports. And so that basically, so for the AI people out here, I'll give you a little bit of background on AI. So that basically is a joint ontology terminology network that they basically use then machine learning for their part of speech tagging and for all of their other things, disambiguation, et cetera. And so that pulls out all these things in the radiology report, and that includes lung grads, nodes, et cetera. And so this is a really cool tool that helps with screening of patients for lung cancer, because if a patient comes in, you want to make sure that you're capturing that data in a structured format so that you don't miss them, and so that you can follow up and you can keep calling them and say, hey, you know, you missed your next low-dose CT. You need to come in and you need to do this because you had this many nodes and this lung grad score. So but we're doing a lot of stuff like in that way, workflow processing.
Right.
Oh, and patients. And so from a patient perspective, so my research is a little bit more on the precision medicine multimodal aspect, which you also touched on. And so, for example, if a patient has let's say lung cancer again. So if a patient has lung cancer and they are stage 3, stage 4, and they need to go on an immune checkpoint inhibitor, that's between 15% and 60% effective. So they have no idea who it is going to work in. And it can get a durable response with 1 dose of it, or it can get a durable response with 5 years, 6 years, et cetera, or nothing at all. And so basically they need to figure out why and how does this work and who does it work for. In the clinical trials, they left out a lot of people of color. And so there were very, very small percentages, about 5% only of Black people in these trials, which is not acceptable. And so basically, my research looks at, okay, can we take a bunch of multimodal data, including some of these psychosocial factors, including some of these social determinants of health or social drivers of health, and basically kind of incorporate all of this information in order to improve the efficacy of these. And basically, let's say as a patient, I come in and maybe some of the stressors I have are the transportation or something like that. Maybe I can improve that and get a referral, or maybe get Uber or something to pick me up, right?
That sounds great. So David, I'm going to swing back to you. We're going to hear a little bit more about Empire AI from Dr. Shang, which is like so exciting. It's a huge investment on the part of the state and multiple institutions. You are at a higher level. You mentioned you've been in all these other places. What are the places that are pushing the envelope in AI in terms of health systems and schools and education? Can you just touch on a few things across at
Yeah.
the high level?
I'll share maybe some experiences that we've seen, starting with the University of Michigan, which was one of the earlier sites to embrace generative AI and allow all of its students and faculty and researchers to utilize it. We all know that you can go on the internet and you can start doing stuff, but that's not really a good idea because you may be putting information that goes into the public domain. So the first thing they did is they set up a secure tenant, cloud tenant that allowed them to be able to then manage all that information. And so everything that is done in the privacy of the Michigan, cloud tenant. And so what we saw was that students and faculty could then leverage the existing GPT models to be able to, do queries. Now what they're building is they're building out an AI agent that will ask or basically guide people down some of the most common challenges. So if you think of students and researchers, there are probably some very common things that they want to do. They want to navigate the system. They want to understand how to utilize, the different types of resources that are available. And so these agents are being created that will help support them. So this is a really exciting opportunity to elevate the performance of everyone within the organization and also guide them down a way that's being done properly. Now, also Michigan, Duke, Texas, and a few other places around the country are starting to think about this other concept of can we change the paradigm from AI being a way to take away jobs to how can we create jobs? In many places across the country, healthcare is the predominant way to create jobs. You know, if you look at even in Detroit, where we think of it as the Motor City, there are more healthcare jobs in Detroit and in the state of Michigan than there are automotive. So the reality is healthcare is a great starting point if you want to start thinking about how do you use AI to create jobs. So how do we move away from this concept of, okay, we know it can do great things, but there's jobs here on the other end. We actually have to build a bridge. And that bridge starts with a variety of different things that need to occur. One of which is giving people the foundational elements of, you know, AI, data science, bioinformatics, and responsible AI. And then the second is teaching them how to utilize some of these tools. We have something called a promptathon idea that has been deployed at multiple sites across the country, beyond those three that I mentioned, including Stanford, NYU. Actually, it was first done at NYU, Stanford. And what a promptathon is you take like some of the most common use cases for generative AI. And oftentimes it's not even with clinicians, like with the HR team, the finance team, the call center agents. You bring them, legal is very common. And you bring these folks who are like, they may be a little skeptical about this because maybe they tried it, didn't seem to work. But what you do is you walk through a few scenarios. You'll say, okay, what we're going to do, and I'll use HR as an example, is we're all going to use this tool to create new job descriptions, because this is something you do every time, you're all the time. So everyone kind of do their thing. Now what we're going to do is we're going to do it together, and we're going to do it in a structured way. The first is everyone type in, I am an HR manager looking to hire this type of position. Here are the other job descriptions that we put into place, and I'd like you to kind of emulate this. And now I'd like to actually figure out what is the specific things. I would maybe add a few more things to it. And then you get a response back, and then don't stop there, but then respond back and say, well, I like this, but I didn't like this. Can you modify it? And that ability to do that iterative conversation by just explaining the scenario, grounding it with the appropriate information, and allowing you to be able to then have that conversation has been highly effective. And we've seen that after these meetings or after these sessions, about 80% of people will say that they're going to continue to use generative AI. It's extremely valuable for people to have hands-on experience. Otherwise, they will come in with their own perceptions, because typically they did it and they didn't get a great result. Usually it's because they're asking a very specific question and it's not done in sort of a conversational way. So that's the second point. But the third piece, which is really missing, is there is a job at the end. In fact, if you look at a lot of healthcare organizations, there are jobs for cybersecurity, there's jobs for cloud, there's jobs for a variety of different things. But most organizations don't hire for skills, they hire for experience. They look to see, have you done this before? And so what we're now starting to realize is that if you can create a program where people can essentially learn the experiences, almost like an internship type of thing, at the end of the rainbow is a job, not just a degree. And that's what we're now starting to realize. If we can create that bridge, then we can change the paradigm. But that's not just going to be universities. It's actually going to be universities, industry, and local business leaders in the area that are trying to get jobs for their people. And I think that combination is going to be the formula for success. But we're still incubating this, and hopefully we'll get some learning soon.
So you don't know a lot about Buffalo, but Buffalo is about creating jobs and economic development and making Buffalo the place to come, right?
Yeah, fantastic.
And so one of that is about, building startups and bringing in new researchers like people in this room and getting more grants and all of that. But the other second part is about making sure that the community is healthy and can keep people healthy, so that major companies want to not only come here, but stay here so they can get great high quality care. So I love that. And we have a new curriculum in our school, and we have residents, and everybody wants to learn the AI. So really applaud that. I'd love to know about telemedicine and wearables. When people think about AI and technology, and I see you're smiling, you know, and keeping people out of the hospital. Is anybody here doing that, or do you have experience with that?
I can share an experience. So prior to joining Microsoft, I was 6 years chief medical officer at Samsung. And like when you're at Samsung, all you're thinking about is the phone and the wearable. So like for me, that was my life. And I'll tell you, there's something called the digital health paradox, which is the majority of people who are likely to adopt digital health are the ones least likely to benefit. And it's the flip
Yeah.
side. The ones who you actually want to use it are the least likely to utilize it. So this whole concept of like giving them a wearable and expecting them to get better health by looking at the results is great for the worried well, but not for the patients with chronic disease.
Great point.
So what we learned was that you have to actually put it into a program. And the program has to start with giving people a choice that's pretty clear. So at Kaiser Permanente, where we launched this program, we looked at the problem. The problem was cardiac rehab. And cardiac rehab at KP traditionally had very low completion rates. 42% was the starting point. That means after a 6-week program, you know, people coming in 3 times a week, 42% of the people are doing this and they complete it. The majority of people start it, but they don't complete it. And this is not true of KP. It's true of throughout the entire nation, and it's cyclical. Like during the
KP is
winter, Kaiser Permanente, right?
Across all of
Across all of-
California, but the largest healthcare system in California.
Right, and then also in other states as well.
Yep.
And so what they did is they said, we're going to change the paradigm, because we actually asked the cardiologists, and this was the learning. We asked them, oh my gosh, you need to put a Holter monitor because these patients had a heart attack. You know, are we? They're like, no, most of these patients are very low risk. All we're trying to do is we're just trying to exercise them. And we just want to do it and know what's going on. And so we said we could put this on a smartwatch and we're going to see how they do. So they were given a choice. You can either come into the facility 3 times a week for 6 weeks, or you can go home with a smartwatch. Almost everyone chose the smartwatch option. Okay, 80%. Now here's the thing. If they didn't wear it, they'd get a phone call. And somebody would call them and say, hey, we noticed you're not wearing it. And then everyone started using it. So the completion rate went from 40% to well over 80%. And the readmission rate dropped from 11% to 1%. And that was with 200 patients. They scaled it to 1,200. They saw the same results. And now the late Bernard Tyson, the CEO of Kaiser Permanente, said we should be doing this across all of KP. So now it is first-line therapy alternative to in-person across all of KP. There's been over 35,000 patients that have enrolled, same results. It's one of the largest digital health programs that with good success. But the thing is, I mean, what makes it successful? You know, KP is a combination of the plan with the providers and the fact that they're not focused on who's getting paid for all this stuff. And so because of that, there's a certain environment that they tend to work in. It hasn't gotten widespread adoption, largely because of the whole business model and the payment. But the technology and the approach actually works. And I think if we were to think more about how we can align payment with it, we could probably get greater adoption.
So KP though, I mean, if someone gets in the hospital, they got to pay for it, and you know, so that's the benefit to them. So
Yeah.
I mean, that's great. That's terrific. So are we using any wearables or telemedicine here in our community in terms of this AI opportunity, Don?
Sure. So you might know that the Visiting Nurses Association is part of the broader Kaleida Health System. Catholic Health System also has a very strong visiting nurses program, but we do within and we cover 10 counties, the 8 counties of Western New York and into Rochester, but we do have remote patient monitoring that we do through our home care organization to be able to have ongoing, and with a centralized call center to then be able to reach out to the patient should there be something that needs to be. It's predominantly been focused in the areas of cardiovascular disease, particularly on CHF as one area. And then telemedicine we do use because we do have relationships with many rural hospitals. We are using telemedicine, particularly in consultation. Sometimes our cardiologist, for example, Dr. Vijay Iyer, when he said we're doing telemedicine consulting visits to remote parts of Western New York, just to improve the efficiency for our providers and for patients, right? We all know the challenges that you can have sometimes at times of the year in navigating the roads of Western New York. And so rather than have patients travel, just have care in the community. So those are just 2 quick examples.
So we have time for one more question, and I think it's really about how you as leaders see the operational effectiveness of AI. I think when we think about it, we talked about the notes. What about blocking and tackling how you run your systems.
Yeah, I think the ability to predict what the flow is going to be into the hospital. So, if we've worked in a trauma center and it's a really nice weekend, you're like, oh no, here we go. It's a really nice weekend. That this is going to be really, really busy this weekend. But that's obviously anecdotal. I think the ability to predict and use clinical and non-clinical data to predict what the volume is going to be coming into the ED,
Great point.
being able to staff for that. And then on the other side, staffing piece, right? We know certain things like Mother's Day. We're going to have a lot of call-offs, those types of things. And these are very basic examples, but there's many, many factors that come into the ability to staff appropriately. And then on the other side, the ability to predict, even if it's, days in advance, for the individuals that are coming into the ED and then coming into the institution, we have expected length of stay and those types of things, but really being able to predict what's going to be happening a few days later in the building so that we can plan for the types of patients that are in there, both again, clinical information and non-clinical information. Those are some of the things we're excited about and we're beginning to look into. And then just very quickly, the payers are ramping up with AI to not pay us. So we're ramping up on the other side and talking to a lot of companies about ways in which we can use AI. And Dr. Rhew talked about some of the tools that are being used in that regard. But it seems to be an arms race a little bit around that too, around the payer side. So
Yeah, that's a great point. And did you want to make one? And then
Yeah,
we're going to open
really
up to
fast.
questions we have 10 minutes.
So yeah, at Roswell, we've actually done some of that stuff. So for chemo infusion, we're using a tool that uses probabilistic machine learning
Yeah.
to basically put people in chairs at the correct time. And the efficiency of that, oh my God, it's been completely drastic in comparison to what was happening, staffing issues, et cetera. It's so hard to predict. And like people were being scheduled at the same time before it. And it was just a disaster and a nightmare. And so now we're just using that and it's great.
So I think if you can predict from the time the patient either walks in the clinic or walks in the door that this patient is going to have a long length of stay and this patient is probably going to be, and then, you can throw available wraparound services to this subgroup, you will be able to do predictive modeling and save a lot of money and improve outcomes. We're going to open it up to the room and Jill's got a mic and Peter Elkin. Peter is a chair of Bioinformatics here at Jacob School and an amazing leader.
Thank you very much, Dean Brashear, and thank you for the wonderful talk. It was really quite eye-opening. So before I ask my question, I'd like to just say I'm very much in favor of getting AI integrated into the practice. And the way I see it is to prevent medical error, which is the big opportunity. So if you think about it, any of you ever go bowling, and you put up those guardrails on the side so you can't hit a gutter ball, right? That's the first thing we're going to do. We don't want any doctors throwing gutter balls, right? Then we're going to narrow it in so it's always a strike, right? So my question though is, and this is something that's been bothering me and worrying me, is our current practice in the country is biased right now. If we build AI algorithms off of biased data, won't we just be perpetuating that bias? And how do we build a system that's better, that helps us to lead to an unbiased representation of care?
Thank you. Who wants to answer that one?
I can tell you, we think a lot about that as well, not only at Microsoft, but also across the broader coalitions that we are part of, whether it's Coalition for Health AI, Train, or other organizations. I think that what most organizations are starting to realize is they need to start and trying to get their own house in order to apply some of the basics. Things that I'd already talked about. Do you know what AI is running in your system? Do you have a registration portal? Do you have model cards? Are you testing it on local data sets? If you're not testing it, there's no way to know whether it's actually working or not. Are you following and looking at outcomes post-deployment? Do you have specific elements of how you're assessing bias? And if you're testing for it within that capacity and you say, we've tested it internally and we feel like it is as good as we can feel relative to meet our standards, then you can start deploying it. But that's not good enough. You actually do need to collaborate with other sites, because if you want to truly test it in other populations, you just don't have enough patients it's just the reality. No one site has enough diversity and large enough patients. So That's why this whole concept of collaboration is so essential. Train is now it started as a national network. It is now an international. So as you think about population sets in other areas, but it has to be standardized, it has to be structured, and it has to be something that is done with privacy preserving federated processes in place. So I think it's all of those, but the starting point is just kind of get your own house in order by following the basics.
Don?
Dr. Elkin, I will just add, and I know Tom does as well, it sounds like Roswell and Catholic Health may as well, but I know that what we've established is an AI review board. So we've got a whole governance structure that we've built around AI. I was pleased to see the 4 questions that you put up in the CHI reference, because that's the model that we're following internally to make sure that we're trying to, as we adopt it, that we adopt it responsibly. We like to say if we do, we call it AI done right. If we do it right, following that process, that we can eliminate it. But I think you're asking a different question, which is really around those that are developing those algorithms and models. How do they do that? So what we're looking for is really to integrate solutions within our current products rather than adding additional products to as another either point of failure or a point of bias. So those are the ways that we're trying to manage it, at least now as we're starting out on the journey.
Yeah, so I think so I'll talk a little bit, I'll put my research hat on. So talk a little bit about like training, right? So I think federated learning is one way to do this, right? So basically taking a bunch of different institutions' data and building a larger model. I think another way is simulation and this generative AI, and essentially teasing it and saying, okay, I need more patients of this type of population. I need more patients that have these outcomes. And essentially then throwing it through these predictive algorithms and seeing what comes out, and then having a clinician look at this data and say, hey, are these like real false like positives? Are they not? Like what's going on here? And then I think another way to do it is also then if you build an in-house system, it shouldn't be used until you test it externally multiple times. So currently we are working with the City of Hope to do a model like this, looking at 90-day mortality, and basically just to have that conversation of palliative care with your patient. But they have a completely different cohort than our cohort and a completely different patient population. And we want to see how good their model is and how good our model is at predicting these things, basically to see if somebody shows up that looks like someone at City of Hope, can our model predict this? Can it do it well, or are we just going to completely miss them? So I think it's a lot about like that training data, making sure it's clean and standardized, which is a huge, huge issue.
Questions? Middle here. And can you tell everybody your name and where you're from?
Sure. I am Lars Peterson. I'm a associate professor in emergency medicine, critical care, and neurocritical care, and I practice at Kaleida, specifically Buffalo General. And I also
Thank you for doing that.
I'm a clinical ethicist at my prior institution, and do clinical ethics consultation. And it strikes me that in our current regulatory environment, with the post-Loper-Bright was the Supreme Court decision that said that federal agencies, when they promulgate regulations, that may not be the end part of that regulation. And our current legislative structure leaves a lot to be desired. And so my question is, how do we enforce all the altruistic values that you guys are talking about, other than just hoping that the market forces, as nebulous as that may be, makes people act appropriately? Because as a physician, I'm proud to practice in a tradition that's spanned thousands of years. But it seems like in the next coming decades, a lot of that thousands of years of cultivating our ethics and cultivating how do we treat patients may be in jeopardy.
David, I'm going to let you take that one.
I mean, that's a great question. And I think one of the things that we are seeing is that there's regulation that's coming at multiple different levels. Regulation at the federal level is where most people focus on, specifically looking at ONC would be one, FDA, HHS, and we're starting to see some of those kind of take hold. There was something that was, I'm not sure if you've been tracking something called OCR 1557, which if you were to read to the letter of the law, it applies to AI as well. And it
You wanna
specifically.
unpack that a little bit more.
Yeah, there's so within HHS, as part of the Office of Civil Rights, I guess I don't know if you call it amendment or a proposal that it was ratified. There was a proposal called 1557, and it specifically asked that any type of algorithms or decision support needs to be unbiased. And so, like, to the issue of bias is becoming a central point for a lot of the regulations that are out there. And there's many stakeholders that have concerns about this, and they're applying this into healthcare. There was a legislation that was recently passed in Colorado that they specifically ask that all healthcare providers follow their rules, which essentially means that you have to determine if any algorithms have potential bias, and they specifically call out things like age, race, gender, ethnicity, things like that. And so we're starting to see states take a hold and move quicker than the federal government. The federal government has actually said, we are waiting for the industry to help figure out this together, but the states are moving faster. Other parts of the world, like in Europe, they've put out rules that have kind of been very forward. And so what we're now realizing is there's a little bit of a catch-up that has to occur. If healthcare organizations wait for regulations to occur, these regulations may not make a lot of sense.
Yeah.
And so it is important for us to very quickly set up the processes, demonstrate the value, and then go back to the policymakers and legislators, say, this is how it is being done and it should be done, so that the rules that are put in place will reflect current practice, as opposed to some kind of a general rule that's put in place and everyone's struggling figuring out how to work it. And that's where we're at right now in certain states. I think New York, you have a little bit of a buffer right now in terms of being able to build that out and demonstrate it, but other places around the country and the world.
California had
not so
something
much.
come out, I think it was
California-
yesterday, right?
California
Governor said no.
So California has had a couple things. The Attorney General specifically asked for something very similar. That never got passed or never got kind of moved. They never moved forward with that. Then there was something that was recently passed, but it was more on the payer side. But I can very easily see this extending to providers. So California will likely be next in terms of that, and then you're going to see other states as well. So, this whole issue is very big, and it's not something that we can sit back on.
Right. Last question.
So I'll just speak loudly. I'm wondering,
Really?
I'm trying to think of a different stakeholder, and that is the firm. So firms are claiming that the fastest growing number for them are healthcare costs. So if they were to take the lead and say, how can I integrate AI into my employee base and processes so as to decrease my healthcare spend while improving the outcomes for the patients, what could they do?
Sure. Well, I think part of it, so think about Kaleida Health, we're self-funded, right? So what that means for all of you is that we effectively pay for our 17,000 dependents, so our employees and their loved ones, we pay for all of their medical costs.
Same,
Right?
I can hear Satish is.
Satish is saying the same thing.
That was
So-
same for you, B.
So part of the opportunity, and this is where we have to be when we say AI done right, and when you think about protecting people's privacy. So we have all of the access to all of that information and the claims and the knowledge of what are those disease states. So there are 5, we just looked at this yesterday, there are 5 very common things that are prevalent within our dependents that we provide health insurance to. So now it becomes, how do we utilize that data to curate particular solutions in terms of, and so this is something that David alluded to, but I think I'll just kind of build it out. The idea of the 80-20 rule, right? So that only 20% of someone's health outcomes is really related to the care that they receive. 80% is attributable to many other things. And you touched on it. 30% of it is attributable to your personal health behavior. So diet, exercise, et cetera, right? So to the extent that we can look at that data and then develop specific programs like you talked about at Kaiser Permanente, to have people have greater access to their information, understand what's driving their own health and their health outcomes, and then their own cost is, I think, a winning formula for the future of how you can influence behavior, because people know what the right thing is to do, but how do we make it easier for them to do the right thing? I don't know what you would think about that, David.
Yeah, I mean, first off, I think the whole economics of healthcare have to be front and center as well as the clinical benefits.
Right.
Because you can have a great product and a great idea, but if you don't have the people and the resources to do it, it never gets launched. And to get the economics in place, focusing on things that right now I'll call low-hanging fruit. Right now, as we alluded to before, there is a bit of an arms race. When AI was launched, the payers took full challenge, the full opportunity to do a comprehensive documentation and review all the things and say, hey, you're missing this, and they're absolutely right. They are missing it
We're
based
not
on the
gonna pay for
protocol.
that.
But if you're not doing the same on your end to say, hey, we actually have it here and here, you will actually see decreasing reimbursements. And we are seeing this nationally. Higher rates of denial are going up significantly. So there has to be some mechanism to be able to stay on top of all of this. And AI can help in terms of not only reimbursement, it can improve overall efficiency. There's so many different areas and opportunities. So I would say, focus on the economics, but that helps fund all the great, amazing things you can do later on.
So I want to give a round of applause for our panel, please. So since we're about transforming health, we have some gifts for you. Dr. Cizek is going to pass out just a small token of our appreciation. And then we have a bigger UB packet complete with we'll have similar
Great.
chocolate in there.
Thank you.
All right, thank you all.